You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is Jon Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for January 17th, 2025. This week, renal denervation, the obesity paradox crushed. JACC devotes an entire issue to the FINEARTS trial of Finerenone and HFpEF, disappointing kidney outcomes for Finerenone, a setback for one PFA system, and coffee. First up is renal denervation. CMS has called for public comment regarding coverage of renal denervation for the treatment of uncontrolled hypertension. I actually went onto the CMS site and made a comment myself. 2 systems for renal denervation have cleared FDA approval, an ultrasound-based device and the Simplicity Spiral RF device. Uptake of these devices have been slow or non-existent, and the reason? Funding. My take is that there should be funding issues. Recent sham control data is not only not impressive, it's in the range of 5 millimeters of mercury, but there is no data on long-term effects beyond 6 months on blood pressure, and there are clear non-responders in these trials. Proponents of renal denervation say that there are open-label extension studies which confirm the benefit over long-term, and I respond to that by saying that open-label anything is essentially worthless for renal denervation, and I would cite here the Simplicity Hypertension 1 and 2 trials, which were highly positive, but then the sham-controlled Simplicity 3, which was negative. Long-term efficacy of renal denervation is also worrisome because there is no reinnervation of the renal system in animal models. What's more, we know that distal ablation is needed, but we have no measures of successful ablation with renal denervation. When we ablate in the heart, we see the effects. Patient selection is also very difficult. The trials had substantial numbers of non-responders, and it wasn't really predictable. In sum, I see renal denervation as a failure of proper regulatory oversight, and it is science that strove to clear a low bar. I will cite a controversies paper in the American Journal of Medicine. The first author is Filipponi, which lays out what a proper renal denervation trial looks like. If we really wanted to know the efficacy of this procedure that could be done in millions of people because of the prevalence of hypertension, such a trial would be sham-controlled, double-blind. There'd be adherence assessed with blood and urine samples. There'd be maximal medical therapy in both arms. Crucially, there'd be long duration, 2 years, maintaining sham blinding. There'd be target ambulatory blood pressure, not office blood pressure. They would use second-generation devices. They would assess the number of meds and quality of life, assess structural and functional target organ damage, and relate those target organ effects in the kidney to changes in blood pressure. We would assess MACE, major adverse cardiac outcomes, as well as cost efficacy. Now, I realize this sounds like a high bar, but I see it as necessary because if not, can you imagine the cost and potential waste and harm if this procedure is let loose in the wild world of private fee-for-service healthcare in the U.S.? You think GLPs are costly? Hypertension is as common or more common than obesity. Professor Franz Messerly has a nice editorial out in JACC, and I will cite it. It's titled Renal Denervation, Antihypertensive Therapy or Gizmo Idolatry. He urges us to balance the benefits of renal denervation against generic amlodipine, which easily reduces blood pressure by greater than 10 millimeters of mercury in a day, a week, or over years. What's more, if renal denervation works, it blocks sympathetic activity. That's the same mechanism as beta blockers, and beta blockers are consistently inferior for reducing outcomes when compared to other antihypertensive drugs. I am glad CMS is moving slowly, and I am glad there are funding issues. with renal denervation. Thank goodness. Next topic is that JACC has dedicated an entire issue devoted to one trial, the FINEARTS trial. I covered FINEARTS when it was published in New England Journal of Medicine in the late summer during ASC. Recall that Finerenone is the first MRA, mineralocorticoid receptor antagonist, that is non-steroidal. Unlike spironolactone and eplerenone, patients on Finerenone don't get steroidal side effects like gynecomastia. I will now excerpt part of my September 6th This Week in Cardiology podcast on the FINEARTS trial, which had 6,000 patients with class 2 to 4 heart failure, EF more than 40%. Patients in FINEARTS were 72 years old and actually had an EF of 53%, so pretty normal LV function. The primary endpoint was a composite of total worsening heart failure events, which could be an unplanned heart failure hospitalization or an urgent heart failure visit, and cardiovascular death. In over nearly 3 years, the primary endpoint of total heart failure events and CV death occurred in 14.9 per 100 patient years in Finerenone versus 17.7 per 100 patient years in the placebo. This was a hazard ratio of 0.84, a 16% relative risk reduction that was statistically significant. The composite endpoint was driven by an 18% reduction in heart failure events, but the rate of CV death was not statistically significantly different. It was 8.1 versus 8.7. The results for the primary outcome were consistent across all pre-specified subgroups, including those defined according to baseline ejection fraction and baseline use of SGLT2 inhibitors. Death from any cause was not different. The original paper included the difference in change from baseline in the KCCQ total symptom score. It was significantly better on Finerenone, but the absolute difference in mean was only 1.6 points, well below what's clinically significant. Remember that KCCQ is 0 to 100. Total adverse effects were similar, but in the Finerenone arm, 3% versus 1.4% of patients had a potassium greater than 6, though no episodes of high potassium led to death. I also mentioned back in September that this Finerenone has been shown to reduce the risk of kidney disease progression and cardio events in 2 large trials in patients with CKD. That's the Figaro DKD and Fidelio DKD trials. My main criticisms of FINEARTS at the time was that it basically replicated the America's part of TopCat, which studied spironolactone versus placebo in HFpEF. Recall that TopCat overall trial results were negative, but if you exclude 2 of the countries, Russia and Georgia, which had serious irregularities, the trial was positive. There, I will cite a regional variation TopCat paper in circulation. My second criticism of FINEARTS was that Finerenone should have been compared to generic spironolactone. With FINEARTS being positive, we now have 2 drugs that are better than placebo, but a comparison study would have been the proper scientific question. My third criticism was that the differences in FINEARTS were modest. In a 6,000 patient trial, there were only 200 fewer heart failure events and no difference was seen in CV death. Finally, neither the main FINEARTS paper nor many of the other related publications did not break down the heart failure events. We don't know how total hospitalizations were affected. And I'm going to tell you about some FINEARTS sub-studies, but none of them tell us about the total hospitalization burden, which is obviously critical in 72-year-old patients with HFpEF. All right, back to this week. Editor-in-Chief Harlan Krumholz writes in his intro piece that this themed issue underscores JACC's commitment to advancing cardiovascular science by curating key findings and analyses around transformative trials. Quote, by bringing together complementary papers, this JACC issue provides a comprehensive view of the trial's implications for clinical care and future research. And he included a nice figure in his editorial, a figure that you might see as an advert for the company reps hand out when they come with free burritos in the doctor's offices. All right, now to the papers. Sub-analysis number 1, this was Finerenone in patients who had a recent heart failure event. Now, in the main FINEARTS paper, there was a subgroup based on when patients were enrolled since their heart failure event. They could be enrolled within 1 week, a week to 3 months, or more than 3 months. The patients in the first 2 groups, within a week or within 3 months, had hazard ratios less than 0.80, whereas patients with distant heart failure events before entering the trial did not seem to benefit from Finerenone. So there seemed to be a heterogeneous treatment effect. Now, instead of just a subgroup in the New England Journal of Medicine, we get a whole new paper. It's basically what the main paper showed in one sentence. First, there was a twofold higher rate of primary outcome events in those enrolled early after a qualifying heart failure event, which kind of makes sense, right? Compared to placebo, Finerenone appeared to lower the risk of the primary composite to a greater extent in those patients who enrolled 7 days from their qualifying event or 7 days to 3 months from their qualifying event. But the P for interaction did not reach statistical significance, though it got close at 0.07. The authors then did something I don't quite understand. They calculated the absolute risk reduction for the three groups. It was 7.8 absolute risk reduction for the 1 week group, 4.6 for the 1 week to 3 month group, and then just 0.1 for the greater than 3 month group. They then say this is statistically significant for the trend across ordinal categories. So I don't exactly know how that differs from P for interaction. JACC then let the authors conclude that there was a, quote, possible signal of enhanced absolute treatment benefit with Finerenone in those who had a recent worsening heart failure event. However, in the limitations, the authors seem to nullify all this by saying, quote, although treatment effects appeared to be greater among those enrolled proximate to a worsening heart failure event, in the primary analysis of total heart failure events and CV death, there was no definitive treatment by time interaction, and the secondary analysis of time to first occurrence of CV death or heart failure event did not suggest the same pattern of diminishing treatment efficacy over time. Now, they do say that this is hypothesis generating, and it will be studied in another trial called the Redefined HF study, which is good. This sub-analysis also included a favorable editorial there in JACC. All right, sub-analysis number 2 is the effect of Finerenone on the KCCQ in patients with HFpEF. Now, change from baseline KCCQ into two groups, Finerenone versus placebo, was a secondary endpoint of the main trial, and it was in favor of Finerenone, like I just said, but the difference was small, at less than 2 points on a 0 to 100 scale. This sub-analysis paper looked at the effect of Finerenone in patients with differing KCCQ baseline scores. But the first thing to note about FINEARTS was that these patients had really good quality of life. The mean KCCQ score was 70, and many patients had essentially normal KCCQ of greater than 80. Now, the authors made 3 groups based on tertiles, right? Low KCCQ at less than 57, medium quality of life at 57 to 81, and KCCQ greater than 81. And it turns out that Finerenone reduced the primary endpoint nearly as well in all the 3 categories. However, quote, compared with placebo, treatment with Finerenone did not reduce mortality caused by CV or all causes and did not improve New York Heart Association functional class across the tertiles of KCCQ. So in the end, there was no heterogeneity based on baseline functional capacity. They then restated the 1.62 point mean improvement from the main trial, but then this paper did something else. They added what's called a responder analysis to sort out the quality of life signals. Now, responder analysis is complicated, and I spent some time reading about it. In fact, the JACC issue included 2 papers explaining how responder analysis works and all of its limitations. I'm not going to go into the whole thing about responder analysis, but basically a responder analysis is looking at the proportion of patients who achieve a desired predefined level of response. So the number of patients who get a greater than 10 KCCQ, for instance, can be a responder analysis. And it turns out that in this paper, the responder analysis is not that impressive. The authors simplify this by saying, quote, numerically more patients in the Finerenone group had clinically meaningful responses compared to placebo, but then they actually sort of nullify that by saying in a sensitivity analysis using categories of KCCQ. that were small improvements, moderate improvements, large improvements, and very large improvements, they write, quote, there was no evidence of benefit with Finerenone. Now, they include a highly favorable discussion saying that this data supports the conclusion that Finerenone is an effective therapy for improving health status in patients with HFpEF, and it was consistent across subgroups. Now, this isn't exactly a false statement, but it also isn't very clear. It is that the improvements in FINEARTS were tiny and hardly clinically significant, regardless of the statistical method used to present the data. And to be honest, even with this paper in JACC, and an editorial, and 2 explanatory papers, it's really basically the same as in the main paper, that the increase in KCCQ was tiny. All right, subanalysis number 3, Finerenone obesity and heart failure with HFpEF. Go back to the main New England Journal of Medicine paper. The authors tell us results based on a simple thing, BMI less than 30 or greater than 30. In the non-obese category, the hazard ratio was 0.80, and in the greater than 30 BMI category, it was 0.79, so effective in both from the September paper. Well, again, now we get a whole paper where the authors break down categories. They go to more categories: underweight, overweight, obese class 1, obese class 2, and obese class 3. The median BMI in FINEARTS was 29.2, and the main finding of this is the effect of Finerenone on the primary outcome did not vary by baseline BMI. All of these categories, normal or underweight, overweight, class 1, class 2, they were all substantially reduced with Finerenone. And when BMI was examined as a continuous variable, the beneficial effect of Finerenone seemed to be greater in those with a higher BMI, and that P for interaction was significant. Now, this all makes sense, right? Patients with obesity are sicker. They're going to be more likely to benefit from the active treatment arm. So, good, we believe this. Okay, well now let me tell you this. Here's a rub. When the authors used a different measure of obesity, they used waist to hip ratio, they found no such trend. I don't know why that is. It's curious. I'm not sure. Let me know why you think this would be. Now, I want to say something about this paper about how it relates to the obesity paradox, and the authors did mention this. Now, in brief, the obesity paradox, there are probably hundreds of papers describing the observation that in observational studies, there seems to be a protective effect of obesity in patients with heart failure. In other words, patients with low or normal BMI seem to do worse than those who have obesity. Hence the paradox. The paradox is totally 100% fake news. Every single one of these paradox papers is marred by something called collider bias. And that's a type of selection bias wherein if you only look at, say, hospitalized patients, the patients with normal or underweight BMI tend to have disease worse than the patients with obesity does. Hence the appearance that obesity is protective or even healthy. Well, in FINEARTS, as it was in Danish and Paradigm HF, the rates of bad events increased with increasing BMI. There's no paradox. HFpEF patients, like HFrEF patients, should be counseled to lose weight because BMI is a risk factor for bad things. All right, now my final comments on this obesity paper, I'm not sure what all of this adds other than the comments on the obesity paradox, which are nice. Finerenone works in all weight categories, just like what was shown in the main New England Journal of Medicine paper with that simple subgroup. Maybe it is a little more effective in heavier patients. I say maybe. The association was not strong, and it was not seen when using other measures of obesity like waist to hip ratio. And, once again, this sub-analysis is accompanied by a favorable editorial, so there's even more attention to Finerenone. All right, sub-analysis number 3, Finerenone in kidney outcomes in patients with heart failure. Now, again, in the main paper in September, the authors reported on secondary kidney outcomes. This was a composite of sustained decrease in GFR of greater than 50%, a sustained decline in GFR to less than 15 milliliters per minute per 1.73 meters squared of body surface area, or the initiation of long-term dialysis or transplant. This was not significantly different, right, in the main paper, 2.5% versus 1.8%, Finerenone versus placebo, hazard ratio 1.33, confidence intervals 0.94 to 1.89. Notice it's higher with Finerenone. Now you know the drill. Now we get a whole paper looking at kidney outcomes, even though we were told there was no significant difference in the main paper. Their first finding of this sub-analysis is exactly what was written in the first paper, a 33% higher rate of kidney outcomes with Finerenone, but it was not significantly higher. Now, in this paper, they also looked at another metric, greater than 57% GFR decline, or kidney failure, or eGFR slope, or changes in urine albumin to creatinine ratio. I am not a nephrologist, but these seem like a lot of outcomes. I don't know why a greater than 50% versus greater than 57% GFR decline are substantially different. But anyways, the more than 57% decline in GFR was the same in both groups. It was higher in Finerenone group, but it wasn't significantly different. As for the slope of eGFR, Finerenone led to an acute decline early, but did not alter the chronic eGFR slope. Finerenone did reduce, however, urine albumin to creatinine ratio, and that was an effect that persisted throughout follow-up. Some other notable findings: treatment effect did not significantly differ according to the categories of baseline eGFR or categories of albuminuria. However, despite lower event rates, eGFR declined to less than 15, which is a more robust component of the composite, was increased twofold with Finerenone. It was 0.8% versus 0.4%. That's a relative risk of 2x. Serious adverse events, including serum creatinine elevations more than 3, AKI, systolic blood pressure less than 100, and hyperkalemia, were more frequent with Finerenone, especially in patients with a GFR less than 60. The authors concluded something similar to what you would have said in the main paper. They concluded that in FINEARTS, a population at low risk of adverse kidney outcomes, Finerenone did not significantly modify kidney composite outcomes. Finerenone led to a greater reduction in initial eGFR, but did not result in a significant difference in chronic eGFR slope versus placebo. Finerenone led to early and sustained reductions in albuminuria and reduced the risk of new-onset micro and macroalbuminuria. So my comments: taken together, the kidney results for Finerenone and HFpEF were not that spectacular, and certainly not as good as that was seen in Fidelio DKD, a cohort with diabetes and CKD. And why didn't a 30% reduction in urine albumin to creatinine ratio not associate with other improvements of GFR decline and or slope? Sanjay Kaul and Swapnil Hiramath explain in the editorial that the baseline urine albumin to creatinine in FINEARTS was very low. So a 30% decline of a low number is really not that much at all. The CKD trials like Fidelio and Figaro had much higher urine albumin numbers at baseline. Yet they agree that there is a discordance between heart failure outcomes and kidney outcomes. And Kaul and Hiramath raise important questions. Quote, how will the guidelines respond to the discordant effects on heart and kidney outcomes? Are the adverse kidney effects concerning enough to offset the favorable heart failure outcomes? Given similar efficacy and safety profile among steroidal and non-steroidal MRAs, will cost and affordability drive the decision to initiate an MRA in HFpEF? Exactly the right questions. Now, there was another kidney sub-analysis that was a little different and kind of simpler. The first author here was Matsumoto, and they examined the association between the initial decline in eGFR from randomization to 1 month and subsequent outcomes in patients assigned to Finerenone versus placebo. The primary outcome, remember, was a composite of heart failure events and CV death. Now, of the 5,500 patients who had GFR measurements, about 18%, or about 1,000 patients, had a greater than 15% decline, and it was nearly 2 times more in the Finerenone group. So now we have a 2-arm comparison study. We have about 4,500 patients who have no decline in the GFR, and we have 1,000 patients who had a decline in their GFR. And after adjustment, a GFR decline was associated with a higher risk of the primary outcome, heart failure and CV death. In patients in the placebo arm, the hazard ratio was 1.50, but not in those assigned to the Finerenone arm. Here the hazard ratio was 1.07. By contrast, the efficacy of Finerenone was consistent across the range of eGFR from baseline to 1 month. So my comments, I think this is a pretty simple paper, and I think the take-home is that, like it is with all heart failure therapies, with ACE inhibitors, ARNIs, SGLT2, MRA, there may be initial decline in kidney function when these are used in heart failure patients, and you got to watch it. You got to check labs, but you continue the medicine as it appears to provide similar benefits. All right, finally, let's put it all together on this JACC issue. My overall comments. None of these papers overcome my overall worries about Finerenone's evidence in heart failure, namely that it should have been compared to spironolactone, and that Finerenone effects are modest, and we don't know the proportion of heart failure hospitalizations to total hospitalization. The obesity paper added a little. The KCCQ paper confirmed the very modest effects on quality of life. The kidney papers makes you think that there may be some discordance between heart failure and kidney outcomes. Maybe. The sub-analysis on timing seem mostly like a marketing exercise, as it stands to reason that a drug will be more effective when used in acutely sicker patients. Now, I know that most trialists publish oodles of sub-analyses, but the fact that JACC puts them in one issue, each with an editorial, tempts me to think, well, this sort of aligns with the business model of journals, which is supported by industry money. It seemed like it was a lot of advertising for Finerenone. That said, 3 of the editorials, Call and HearMath, and the 2 on the limits of KCCQ analysis, responder analysis, were quite robust in their criticism. That's a good point. Good. Now, in a proper evidence-based landscape, one not dominated by industry, one dominated by evidence-based clinicians and, say, government-funded studies, we would have a spironolactone versus Finerenone trial. And that's what we need to know. That's what a clinician needs to know when we see a patient with heart failure. So until we see this kind of data, I see no reason not to start with spironolactone first for patients with heart failure. All right, next topic, and these are both short ones. This week, Johnson & Johnson got terrible news. It had to halt a post-approval regulatory study of its PFA system for AF ablation due to 4 strokes, and this is really bad news. Now, Johnson & Johnson as a company has had a company called Cardiology Systems, and it's been a leader in the ablation field. They have mapping catheters and ablation catheters and really popular systems. But for some reason, Cardiology has trailed Boston Scientific and Medtronic in PFA systems. Now, electrophysiologists were really looking forward to the J&J system because it would easily integrate into the mapping systems that we already have. And PFA as an energy source looks quite promising. I now have about a 6-month experience with PFA, and I already can't imagine doing AF ablation with RF or cryoballoon. PFA is fast. You likely avoid esophageal injury, and so you don't have to worry about fatalities. Efficacy data with PFA looks similar. The 2 initial systems, the Boston and the Medtronic systems, have not had stroke signals when compared to thermal ablation. Now, the strokes in the J&J study may be explainable. They're going to look at it. But 4 out of 140 cases is a very high incidence of stroke. And this will surely set the company back, and it speaks to the need, I think, for proper regulatory studies of new devices. And I say good on J&J for halting the study and looking hard for root causes of these events. Now, things like this reinforce my conservative approach to new technology. The PFA system that I'm using now has been out in Europe for 2 years. In the U.S., I waited about 6 months before I started this. Then I looked at the data. New devices worry me. I still am triggered, and I'll never forget that low-profile, thin, blue Sprint Fidelis lead. What a disaster that was, and I wished I hadn't been an early adopter of that lead. Finally, we're going to talk briefly about coffee. I want someone to let me know if everything is okay over at the European Heart Journal office. I'm worried about them. I got a message this week from an ABC journalist who called my office between patients about this new coffee study. I couldn't talk to her because I was busy seeing patients. According to this new observational study of about 40,000 adults in the NHANES cohort, if you compare morning coffee drinkers to all-day coffee drinkers, it turns out that the morning drinkers have a 16% lower rate of death. Now, nearly 8 years ago, I wrote a ranting column in which I called for an end to observational coffee and blueberry and quinoa studies because these studies are flawed and biased, and actually, they're equally ridiculous and embarrassing. But nothing has stopped. Nutritional research comparing outcomes with different macronutrient exposures have continued in earnest. Now, it's surprising that the lofty European Heart Journal got involved. That's why I'm worried about them. I hope there's nothing in the food or water there, like red dye or heavy metals. Someone go check on them. Seriously though, the paper's altmetric score is off the charts, and herein lies one of the main lessons of the paper, that medical publishing has a business model, and it is attention. So okay, we still love you, European Heart Journal. We get it. Next time, maybe give us an editorial saying something like, okay, readers, this one is red meat for the BBC and ABC and NBC News. The second lesson from these observational studies is that their main value is to show how foolish it is to even attempt such a study. The authors themselves say all the right things. It's observational. There are baseline differences in the groups. Plus, there's recall bias. But, my friends, I am beginning to think that complaining about these studies is like being mad when it rains. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating. We're now over 800 ratings, which is really cool. Thank you. Until next week, this is Jon Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.